get away from virus and move on to the fungus. Fungus, of course, plural will be fungi or fungi, depending on whether you want to use the British English or American English. Okay, if you have a fungal infection, that would be a mycosis. And if you replace the E with, the I with the E, then it will be plural for mycosis. Okay, so there's no dispute now in terms of a fungus. We know that it is definitely in the plant kingdom. So the fungus is a plant, but it has no chlorophyll. So it's an achlorophylic plant. So it has no chlorophyll. We know that it is eukaryotic, so that means that it will have at least one distinct nucleus that will be visible. So it is eukaryotic. And the ones that are pathogenic to humans. Okay. So in other words, you can have fungi or fungi that are pathogenic, and you have some that are non-pathogenic. Okay. The ones that are pathogenic to humans are usually non-motile. And they have a cell wall that is basically made of chitin. Some people say chitin, but I prefer the chitin pronunciation there. And they have a cell membrane that is made of sterol. And the synthetic pathway for the fungal sterol is also the same pathway for the human cholesterol. So the biosynthetic pathway is the same, and that's why some antifungals can actually affect cholesterol synthesis in humans. And you know, if you affect cholesterol synthesis, you can affect the production of certain hormones, especially those that are related to the adrenal gland, like your sex hormones. Okay. And those that are pathogenic usually reproduce by asexual means. So that immediately tells you that fungi can produce or reproduce sexually. They can also reproduce asexually. The ones that reproduce sexually do so through one of 4 mechanisms. Okay, they can reproduce through plasmogamy, which basically means that it cytoplasm of the 2 partners will mix, and so genetic material will be transferred that way, or through karyogamy, which means the nuclei of the 2 partners will come together, or through genetic recombination. So you're just changing genomes there, and then of course through meiosis. So those are the 4 mechanisms by which fungi reproduce sexually. And in those cases, you usually have sexual spores being produced. So you will know that the fungus is reproducing sexually because there will be sexual spores that will be produced. And if a member of one colony mates with a member of another colony, then you will say that that fungus is heterothallic. Okay, heterothallic. But we still will have sexual spores produced. If a member of one colony stays within its own colony, that is, mates with another member of that colony to reproduce, then you will say it is homothallic. If we can give examples of your heterothallic agents, would be your so-called dimorphics. If you look at the bottom right of the chart that we passed out today, which was also part of your handout, you will see the dimorphics listed there. Dimorphics are heterothallic. And an example of a homothallic fungus is one that is called Pseudolacheria. Pseudolacheria boydii. Okay. It is a homothallic fungus. And sometimes you know that the fungus reproduces sexually, but you cannot find its sexual spores. Such a fungus is called, or the group will be called fungi or fungi imperfecti. And an example of such a group will be your amygdala, Fusicoccum amygdala. That would be an example of your fungus or fungi imperfecti. You know that it reproduces sexually, but the sexual spores are not visible. So those are examples of sexual reproduction. And since the ones that infect humans, of course, pathogenicity in humans are asexual, we will mention something about them also. In this case, you also have some spores being produced. The asexual spores are referred to as conidiae, where singular will be conidae. Conidia, and they are carried on a particular branch of the fungus that is called conidiophore. So the conidiophore carries those asexual spores that are called conidia, and it's through those asexual spores that those fungi can reproduce sexually. Okay. And if we look at fungi in general, we can break them down into three main groups, okay? Just based on the gross anatomy or the gross morphology. You have those that will be your yeasts, and those that are molds, and those that are dimorphics. And pathologically, or in terms of disease production, we also sometimes have a different group that one can refer to as the superficial fungi. That is, those that would produce only superficial infections. Okay. Examples of your yeast you see on that chart, mainly Candida. The Turulopsis glabrata also used to be called Candida glabrata, so it's the type of Candida. And then you have your Cryptococcus neoformis, which causes severe brain condition in AIDS patients. Yeah. So you have your yeast. The yeasts are basically roundish or oval in appearance and shape. And they usually reproduce by budding. So that's for your yeast. The molds have a tube-like appearance. They have a tube-like appearance, and those tubes, they're like twigs. And those tubes, the collection of them we call hyphae. Okay, those are the tube-like structures of your molds. When you have a group of hyphae, they will form a mycelium, and the plural is mycelia. Okay, the mycelium is what the fungus uses to extract nutrients from the host. And the mycelium is also the structure of the fungus that carries those spores that we mentioned earlier, particularly your asexual spores that you call conidia. And when you have a collection of mycelia, that will form a thallus. So thallus is actually like the body of the whole fungus. And that's why we talk about homothallic and heterothallic. Okay, it's the whole body of the fungus. So that's what your molds would look like. The dimorphics, well, examples of molds, you see there, you have Aspergillus, Rhizopus, Rhizomucus, and Mucus, and you have your Absidia. Okay. So those are some examples of your molds. The dimorphics can exist, as you say, that is, two morphologies, dimorphics. So they can exist as yeasts and as molds. Okay. And you see examples of the dimorphics there in that handout. Your histoplasma species, Histoplasma capsulatum, Blastomyces, Coccidioides imidis, Paracoccidioides brasiliensis, Sporotrix shanki. Those are your dimorphics. And we'll mention some about them as we go along. Then you have the fungi that will cause superficial infections only. Okay, so you see those will be divided into your dermatophytes. The dermatophytes will be your microsporum and your epidermophyton and your trichophyton. The dermatophytes mainly cause tinnitus. Tinea basically means ringworm. Okay? And so you just attach the word tinea to the part of the body where the infection is present. For instance, if it's in the head or the scalp, you say tinea capitis. You know, if it's on the body overall, corporis, corporal body, or if it's in the groin area, that's the one that you would normally call jock itch. Okay, jock itch, so it can exist in the groin area, and that will be tinea cruris, because it's usually itching, you know. And if it's around the beard, it will be called tinea barbae. That's the beard where you have the infection. Okay. If it's on the feet, then it will be tinea pedis. And that's your athlete's foot, tinea pedis. The reason athlete's foot is so difficult to eradicate is because it usually involves 2 or 3 dermatophytes. So it's not just trichophyton or epidermophyton. You know, it can involve up to 3 dermatophytes, and that's why it's difficult to get rid of. So there's one that is called versicolor, tinea versicolor. That's the situation in which you see patches of the skin that would change color. It can be anywhere from whitish to being brownish or pinkish, but it will be different patches all over the body, and you'll see hypopigmentation, which is signifying that vesicle. So tinea vesicolor will be a fungal infection of the skin where you get hypopigmentation, and then the color can change anywhere from that white to brown to pink, and that on that skin. Okay. Now, so you have those agents that can cause superficial. Apart from your dermatophytes, you have your pterosporum, which we can highlight. Okay. Your pterosporum species sometimes referred to Malassezia species. Okay. The pterosporum species are actually yeasts in terms of their morphology. Okay. So even though functionally or pathologically you put them under superficial agents, structurally or morphologically, they are yeasts. Your dermatophytes are molds, all of them. But pterosporum species and microsporum. Microsporum egale is also a yeast. But just to highlight that Malassezia, you can see referred to as Malassezia 4-4. Okay. And there's one called globosa, orbiculari. Those are different Malassezia species. That species is the one that is most notable for causing what we just rubbed off there, the vesicle. Okay, so when you see the hypopigmentation on an individual that has that fungal infection, is usually this Malassezia 4-4 that causes tinea vesicolor. Okay. Sometimes it is called pityriasis from the name Pityrosporum, pityriasis vesicolor. Your dandruff is also a fungal infection that is mostly caused by Pityrosporum or Malassezia 4-4, especially this globosa. Okay. And sometimes when you have seborrhea or seborrheic dermatitis, okay, that is also usually due to that Malassezia globosa. And then folliculitis is another disease condition that can be caused by that Malassezia globosa. Okay. So that is an important fungus, basically. In infants, when they have so-called diaper rash is actually a fungal infection. And the easiest way to manage it is just to use one of your azoles, miconazole, ketoconazole, so that we will discuss later. Okay, so those are some examples there. All the other agents listed under superficial infections are molds in nature and in structure, that is morphological. So you just have your Pityrosporum and your Trichosporum being the two that will be yeasts. Okay, what are the types of infection that fungus can cause in humans? You can divide them into three. You have your superficial infections, and then you have your subcutaneous infections. So superficial, and then you have some acute, and then you have some systemic fungal infections. The superficial infections, we've already given some examples there. All your tinnitus, all this vesicolor dandruff, folliculitis, dermatitis, all those are superficial fungal infections. Examples of your subcutaneous fungal infections would be ones like rhinosporidiosis, which will be caused by Rhinosporidium species, like Rhinosporidium seaberry. And that will be one. There's a condition called chromoblastomycosis. Okay. That's also a subcutaneous fungal infection. Fialospora species can cause your chromoblastomycosis. Fonsecae species can also do that. Fonsecae species can cause your chromoblastomycosis. Mycetoma, which is sometimes also called hydromycosis. Hydromycosis, that can also be a subcutaneous fungal infection. It is caused by Hydromycosis majorei. That's the organism that causes mycetoma. And then you can have sporotrichosis. Okay, sporotrichosis, that will be caused by your Sporothrix schenckii, which is a dimorphic. You'll see, I think it's the last one listed at the bottom right-hand side of that chart. That is a fungal infection that you often find in people who are bricklayers, that is these construction people, because that organism can grow on bricks, and once they inhale the spores of your sporotrichosis or Sporothrix schenckii, then you can get sporotrichosis. It is also found a lot in people, individuals that grow roses. So if you're fond of having rose gardens, you are more likely to get that sporotrichosis than the rest of the population. Now for the systemic infections, you can divide those into two. You have those that are opportunistic, and then those that are what you call true pathogenic fungal infection, or TPFI. Okay, T there is just true. Okay. And then, of course, like we said, you have the other that can be opportunistic infections, the ones that are systemic. TPFIs are usually inoculum driven. In other words, it just depends on how much of the spores you inhale, whether you will get a full infection. And they don't require a breakage or an alteration of the host's immune system. So a normal person with an intact immune system or defense mechanism, can get that TPFI. And the normal pathway is usually a spontaneous resolution. Okay. In other words, the fungal infection usually resolves by itself, and that is because there can develop a strong specific immunity to a TPFI. Okay. And it is usually caused by a dimorphic. So dimorphics are the ones that usually cause TPFIs. Okay. And there is always a restriction. Okay. So you usually have a geographical restriction to those organisms. Dimorphics are not ubiquitous. They don't appear everywhere. They cause infections in certain geographical locations around the world. Particularly in the United States, you seldom see dimorphic infection anywhere else. You see some in the US and then some in South America, and that's about it. So the dimorphics always have geographical restrictions. And then, of course, your opportunistic systemic infections can just be the reverse. The patient must have had a cut, or maybe one we can put also here. The portal of entry for your TPFI is always the pulmonary system, and that's the only one. You have to inhale the pain, or somehow it has to get to the pulmonary system for you to have that TPFI. For opportunistic, the organisms or the fungi involved are molds and yeasts, not dimorphics. And so they can exist anywhere, they're ubiquitous, and the patient has to have a cut or something that is an alteration of their defense mechanism for them to get the opportunistic infection. And there's no geographical restriction for your opportunistic infection. And of course, the portal of entry can be anything. It can be through the eyes, through the nose, through the skin. So it's not limited to the pulmonary system. So now that we have an idea of what a fungus is and the types of conditions they can cause, we can now look at how you treat those fungal infections. And the way we would go is the same way we went with bacteria. So the cell wall, which is made up of chitin, and chitin does not exist in human cells. Okay, so when a drug affects chitin, it is specific for fungi or fungal infections. Okay. And then from there we'll go to the membrane and onto the cytoplasm and then the nucleus. So the group we will start with will be inhibitors of cell wall synthesis in the fungus. And the classes of drugs that have been examined relative to their effectiveness against the fungal cell wall, the groups we listed here. You have the echinocandins, pancreocandins, acariaceans, and nicomycins, and polyoxin D. This triterpenoids, that's the most recent group of antifungal agents. There's only one drug so far in that group. And we will take the echinocandins as the representative agents for your cell wall synthesis inhibitors. We'll mention something about your triterpenoids. All the others are still being investigated. Apart from your echinocandins, the nicomycins will be the next. That's one now that has reached a high level of testing in humans. It's called, nicomycin Z. But we will not discuss that. It's not yet a major drug. So the echinocandins, and then we'll just say something about the terpenoids. And the drugs that fall under your echinocandins are your caspofungin, macrofungin, anibulafungin, and risafungin. Okay. And I'll just put this drug here, abafungin. Okay. Abafungin is not an echinocandin. Okay. Just because the drug ends as fungin, people tend to get confused thinking it's one of your echinocandins. But no, abafungin is not an echinocandin. Abafungin does not even inhibit cell wall synthesis in the fungus. Abafungin is a totally synthetic agent that affects the cell membrane function of a fungus. Okay, it inhibits C14 alpha demethylase. That's one thing that it inhibits, and it also inhibits C24 methyltransferase. And due to its effect on those two enzymes, it can alter the function of the fungal membrane. So it's a membrane inhibitor. It is not a cell wall synthesis inhibitor. It is used for dermatomycosis, that is skin infections. As you see, mycosis happens fungus, so fungal infection of the skin. And it is also used for the management of onychomycosis. Okay. And onycho, that is referring to nails. Okay. So it's used for onychomycosis. Onychomycosis is a blanket term, okay, that just covers any fungal infection of the nails. If that fungal infection of the nails is caused by a dermatophyte, the group we mentioned earlier under the superficial infections, that is Trichophyton, Microsporum, and Epidermophyton. If it's caused by those dermatophytes, then of course it will be a tinea, ringworm, tinea unguium. So tinea unguium is a specific type of onychomycosis that is caused by dermatophytes, trachophyton, epidermophyton, and microsporum. Okay. So that's the difference between your onychomycosis and tinea unguium. That little fact can make a difference in how long the patient will have to use a drug. See, onychomycosis can be caused by candida, okay? But it can also be caused by dermatophytes. But if it's caused by dermatophytes, you will call it tinea unguium. Okay. So how you would treat candidal infection versus how you would treat trachophyton infection is different. And so one has to know which one is causing the nail infection. It can make a difference of a whole year in terms of for how long one will take a particular drug. And it's very easy. If it's whitish, like chalkish, it is candida. If it's darkish, it is tinea unguium. And so the drug that one will use will be different. Okay, so that's your abafungin. It is not an echinocandin. Okay, the main echinocandin that we will discuss, because it is the one that is most often used, is your caspofungin. Okay. And so starting with caspofungin, then we can look at its mechanism of action. It would inhibit your beta-1, 3-D-glucan. Synthase. Okay. That glucan is the main component of chitin, which of course makes up the cell wall. Okay, so by inhibiting that enzyme, we can inhibit the production of chitin, and if there's no chitin, there's no cell wall. So that's the mechanism of action of your caspofungin. Indeed, that's the mechanism of action for all of your echinocandins. Okay. And if we look at the spectrum of activity, that is the antifungal spectrum of your caspofungin, it is very narrow, actually. It is good against aspergillus, okay, which is one of your molds. It is particularly good against Aspergillus flavus and Aspergillus terris. Okay. It is also good against Aspergillus fumigatus. This Aspergillus terris is actually the source of lovastatin, your very first statin drug. That's where it was obtained from your Aspergillus terris. The three most common Aspergillus species that you encounter are the fumigatus, the flavus, and the niger. Aspergillus niger. Those are the most commonly species. So in terms of the spectrum for caspofungin, you have Aspergillus, that is a mold, and then Candida species. Okay. So that's the spectrum for the drug. If we look at its admin, we know that the drug is administered by intravenous administration and is by IV infusion. It has to be administered slowly over 1 hour. So by slow IV infusion. And that's another thing that's common to all the echinocandins. They're all administered intravenously. And they all have usually a loading dose before you start giving the maintenance dose. Okay. So for your caspofungin is given IV. The loading dose is 70 milligrams. And that's just one dose. And after that, you give 50 milligrams IV on a QD basis. Okay. So that's its route of administration. In terms of its half-life, the drug has a biphasic half-life. The initial half-life is 9 to 11 hours. And then the terminal half-life is about 40 to 50 hours. So that permits a once-a-day administration of the drug. In terms of its plasma protein binding, it is very high. It's greater than 90%. So they're around 97%. So very high. That also runs through. That is true for all your echinocandins. They all have high plasma protein binding capability. In terms of the metabolism for your caspofungin, it undergo hydrolysis to something that is called DHHT. Okay. And that is a tyrosine metabolite. Dihydroxy homotyrosine. Dihydroxy homotyrosine. And then that can undergo N-acetylation. So you can have N-acetyl dihydroxy homotyrosine. And then sometimes it just undergoes chemical rearrangement, that is just spontaneous chemical degradation. Can just undergo or get broken down that way. In terms of the excretion, the drug can be excreted both renally and fecally. So you can have both fecal and renal excretion of that drug. Most of it goes out through the renal system, but it's the fecal excretion is almost equal, about 6% difference between your fecal and renal excretion of your caspofungin. So they're like 35% versus 41% excretion fecal to renal. Okay, so that's the admin for caspofungin. Indications, we use caspofungin, of course, for the management of candidemia, which basically means a lot of candida in the bloodstream. You can use it for invasive candidiasis, and you can use it for invasive aspergillosis. Okay. You would use caspofungin in invasive aspergillosis after you have tried this drug, amphotericin B, okay, and after you have tried posaconazole. And after you have tried voriconazole, or even itraconazole. These ones are examples of your triazoles, your antifungal triazoles. So before you get to caspofungin, you must have tried ampho-B and those triazoles for the management of that aspergillosis. And in the case of candidiasis, if the candida has become resistant to your caspofungin and has become resistant to azoles, particularly your triazole antifungal agents, that is when one can go to this drug, risafungin. Okay, I can say that as Rizayo. That's its brand name. The drug is administered at a dosage of 400 milligrams IV initially. That's the loading dose. And then you go to 200 milligrams IV once a week. That's another advantage that this risafungin has over these other agents. Microfungin, you can give a loading dose of 100 milligrams IV, and then use a maintenance dose of 50, sometimes 100 milligrams IV QD. Amidulafungin, 200 milligrams loading dose, and then 100 milligrams maintenance dose, also given IV QD. But risafungin is given once a week. So it has that advantage over other echinocandins. And if we look at the adverse effects for your caspofungin, sometimes it can be mild, it can just be your usual nausea, vomiting, diarrhea, and have some flushing, possibly. Okay, and some anorexia or fever can produce those. And then it has some adverse effects that seem to be histamine related. And in such situations, you can see the flushing of the face area and also the swelling of of the face area, that is facial swelling. Okay. And then you can, of course, have pruritus, itching, that may develop some rash and some feeling of warmth. All those can be seen with this drug. Also, because of the vasodilation, blood pressure can come down. Okay. But you can also see a decrease in magnesium levels. You can also see a decrease in potassium levels and a decrease in plasma glucose. So you can produce all of those. The overall or the net effect of the drug on potassium is actually an increase in the serum level of your potassium. So at the level of the serum, you see elevated, that is elevated serum concentration of potassium, and your alkaline phosphatase. That can also increase the serum. Your serum creatinine will also go up with caspofungin. Okay. And if you look at the renal system, you can see an increase in the amount of protein that is present in the renal system. And you also see an increase in RBCs. So when you have a lot of RBCs going out in the renal system, then anemia can develop. So anemia may be one of the adverse effects of your caspofungin. Because if you're losing red blood cells, you can develop anemia. Okay, so that's what we have for the candies. And just before we leave the cell wall synthesis inhibitors, we have to mention the only triterpenoids that is now available. The drug is called Brexafemme. And Brexafemme is a triterpenoid that works that same way. It inhibits the synthesis of glucan, and that's why it can inhibit cell wall synthesis in the fungus. And the drug is actually administered orally. To talk about a little bit about this ADME. It is administered orally. It comes in 150 milligram strength tablets. And we give 2 PO/QM and 2 PO/QPM. And that's it. It's only used for 1 day. It's a 1-day therapy. The drug is a substrate for 3A4, cytochrome P4 3A4, but it is also an inhibitor of 3A4. So it's a substrate as well as an inhibitor of 3A4. And it can also inhibit 2C8, cytochrome P450 2C8. Very high plasma protein binding, greater than 9%, and the half-life is 20 hours. that is 20. Excretion is only through the fecal pathway for your breast. All right. So that's for tracheotomy. And that brings us to the end of the cell wall synthesis inhibitors. So we can rub all of this off. And when we leave the cell wall, then of course we go to the cell membrane. And the cell membrane inhibitors, or agents that affect it, are these polyene antibiotics. When we were talking about polymyxin, under bacteria, we mentioned polyenes as cell membrane inhibitors, but since they're mostly used as antifungal agents, this is where we will be discussing. Since they're all antibiotics, then it means they have a natural source. They're all produced by Streptomyces species. Okay. For your nystatin, it is Narseni. For amphotericin B, it is Nodosus. Okay. For natamycin, it is Natalensis. Okay. And for capsaicin, it is the Griseus, which is also one of it's also the source of one of your aminoglycosides. Riboside is the Rimosus, which is a source of your paromomycin and also two of your tetracyclines. And Philippine is Streptomyces philippinensis. So they're all true antibiotics. The very first antifungal drug made was this drug, nystatin or mycostatin. Okay, that was the very first antifungal made. And if we look at its mechanism of action, we know the source already. So the mechanism of action is simply that it binds to the fungal sterol, which is what makes up the membrane for the fungus. And when it binds to that sterol, when it reacts with that sterol, it will create some channels in the membrane, or holes, if you will. And then you will have the leakage of the internal medium of the fungus out. At low doses, it is fungicidal, and at high doses, it is fungicidal. So it depends on what you give. The ADME, you can't say much about it. We know the formulations, that is the form that it comes in. You have the tablets, and the tablets can be oral and can be vaginal tablets. Okay. Then you have the powder form. You can say one that is oral, that can be reconstituted, into a suspension. And then you have your topical powder, which you just spray on the toes if the patient has athlete's foot or tinea pedis. Okay. And of course, you have the already made suspension, which one can take. And then you have your ointment, topical formulation again. Now, the vaginal tablet can be used, can be placed in the mouth, just on the tongue. If a patient has thrush, because thrush is nothing but candidiasis of the tongue. Okay, so you can place the vaginal tablet on the tongue, and with your thrush, the longer the contact time, the better results you get. So the longer you can maintain that tablet on the tongue, the more effective it gets. Okay, so that's for the vaginal tablet. And even though this oral tablet is swallowed, okay, it is not meant for systemic mycosis. Nystatin does not get absorbed from the GI tract. You don't use nystatin to treat candidemia. It does not get into the bloodstream. So when you see nystatin given as an oral tablet, it is only to treat candidal infections in the GI tract, from the esophagus all the way to the large intestines, but it doesn't get absorbed. Okay. So in that situation, you cannot talk about half-life. If the drug is not in the bloodstream, you cannot talk about half-life. Okay, and so you cannot talk about plasma protein binding either. Okay. And so it would mostly go out, of course, all through the fecal system in terms of the excretion. So indications, you will use nystatin for, like we said there, thrush, is candidal infection of the tongue. Okay. And you can also use it for candidal infections of the GI tract, esophagus, intestines, like that. And for vaginal candidal infection, vaginal candidiasis. Okay. And then, of course, for tinea pedis, that is athlete's foot. Okay. So it can be used for that. And then candidal infections of the skin. So even though if you look at its spectrum, its antibacterial spectrum, in vitro, it can cover histoplasma, which is one of your dimorphics, okay? And it can be effective against blastomyces, one of your dimorphics. Okay? So even though it can be effective against those, it is mainly used clinically just for yeast infections, that is candida infections of this area. And the adverse effects are very, very minimal. You can just talk about some nausea, vomiting, some diarrhea, and possibly skin reaction, like a rash. So extremely safe drug, but not for systemic mycosis. The main polyene we're going to discuss will be your amphotericin B. Okay. Natamycin is just used for ophthalmic infections. It is used to treat keratitis or conjunctivitis or blepharitis that is caused by this organism, Fusarium solani. That is a fungus that normally infects the eyes. And that's a fungus that almost drove Bosch and Lomb out of business, because not too long ago, they somehow in their labs, their ophthalmic preparations were contaminated by this Fusarium solani, and some people got blind. They went blind from the infections of that agent. And we had to pull all our Bosch and Lomb products off the shelves, and then they were reconstituted and got it okay to be marketed again. So that's for your natamycin. That's mainly what it is used for. Candidin is just used for vulvovaginal candidiasis. Okay, so vaginal candida, sometimes called VVC, vulvovaginal candidiasis. That's what we use candidin for. That's the only indication also for linocidin, and Philippine is so far not being used in this country, so we'll leave that as it is. Okay. So now we can look at your amphotericin B. Amphotericin B, you have some preparations that are used clinically. Those are the 4 preparations of amphotericin B. You'll see. The fungizone is sometimes referred to as the ABDC. Okay, because it's amphotericin B that is combined with deoxycholic acid or deoxycholate, ABDC. Okay. Your Amphotec is sometimes referred to as ABCD. Colloid dispersion, that is amphotericin B, colloid dispersion preparation. And Anderson is the liposomal preparation. Okay. Liposomal preparation. And the Abelset is the lipid complex preparation of amphotericin B. So you can say it refers to as ABLC, lipid complex. Okay. The one that is still used the most is your fungizone. It's the oldest, it's the cheapest, but it's also the one that causes the most adverse effects, and yet it's still the one that is used most often. Number one, because it works. Number two, because it doesn't cost as much as your Anderson. Anderson is the most expensive, is the one that is most absorbed, is the one that causes the least adverse effects, the liposomal preparation. And it is the only one that is truly effective in the management of visceral leishmaniasis. It's Anderson. All the other three are not that effective. If you have cutaneous or mucocutaneous leishmaniasis, yes, you can use those other ones. But if it's visceral leishmaniasis, it has to be Anderson. Okay. And usually when fungicide is administered, sometimes we see it, we often see it given with intralipid. That is to improve absorption and to decrease toxicity. So we will administer IV with that intralipid. And when you say lipid complex here, it's actually a combination of DMPC and DMPG at a ratio of 7:3. That's your diamyristal phosphatidyl. Choline, and then diamyristal phosphatidyl glycerol at a ratio of 7:3. Okay. So, having said all those, we'll use fungicide as the representative agent for our discussion. So the mechanism of action of amphotericin B or fungicide will be just like the mechanism of action for your nystatin. The ampho B will bind to the sterol, create holes, and then internal medium will leak out. And just like nystatin, if you give a low dose, it will be static. If you give a high dose, it will be cidal, fungicidal. Okay. So that holds true. But apart from that mechanism of action, ampho B can also cause oxidative damage to the fungus. Okay. So this up here will be 1, and then 2 will be oxidative reaction or oxidative damage to the fungus. And it can also affect the immune system. At low doses, it will be immunostimulatory. Okay? It will stimulate the immune system at low doses. So low doses will be fungistatic, but immunostimulatory. And then high doses would be fungicidal, but immunodepressive. Okay. So it does all of those. And the aspects of the immune system that it really affects will be your prostaglandin, and it also affects the TNF, tumor necrosis factor, particularly TNF alpha. okay? And then it affects interleukin, IL-1, and sometimes IL-6. And because it affects those aspects of your immune system, it can produce some so-called immediate adverse effects. And that's why we dub it amphoterrible, at the hospital. Because if a patient is naive, that is, if a patient has never received amphotericin B before, the first time you give them ampho B, you have a series of adverse reactions. And those adverse reactions are all due to these aspects of the immune system that it affects.
So based on the interleukins being generally they affect hypothalamus, subsensitivity, fevers, etc. Do you actually treat that, being that it's a part of the side effect of medication?
You pre-medicate the patient so that you don't get these adverse effects that will be due to the immune system. And when we get to the adverse effects, we'll separate the immediate adverse effects of ampho B from the chronic adverse effects of ampho B. So those are the mechanisms of action of your ampho B. And if we look at the ADME, in terms of the routes of administration, ampho B has several routes of administration. It can be given IV, it can be given I-vent, it can be given IM, intramuscular, it can be given IT, intrathecally, it can be given intra-articularly. Okay. And it can be given by inhalation, because it can be nebulized and administered through inhalation. And you can give it into the vitreal humor, that is intravitreally. So you can have intravitreal administration of that drug. So it has many routes of administration. And then, of course, it can be given topically, because you have the cream of ampho B and you have the lotion of ampho B that can be used. In terms of its distribution, the drug, well, before we finish, let me just mention that it does not penetrate the CSF. And that's why you give it intraventricularly. If you if you look at your brain, you will see two lateral ventricles. These are ventricles. So you have two lateral ventricles, and then you have a third ventricle, and then your fourth ventricle. At the bottom of these lateral ventricles, you have choroid plexus. Okay. And what does choroid plexus do? It produces your CSF. Okay. And so you can inject your ampho B into these ventricles. It will not destroy brain tissues because of the choroid plexus, which will be producing your CSF. So the CSF will dilute that intraventricular ingestion of ampho-B. Okay. So the reason you use the intraventricular administration is because the drug does not get into the CSF. And also, if the patient has a fungal infection centrally, you have to give the drug intraventricularly or intrathecally. So going through the theca. Okay. And you can also inject your ampho-B directly into the synovial fluid. That's what this intra-articular administration is. You inject it into the synovium or into the synovial fluid if a patient has an infection in the knee area. Okay. It gets a little bit absorbed or distributed to your aqueous humor. So a little bit can go into the aqueous humor, but not to the vitreous humor. And that's why you have to give it intravitreally. You know, if there's an infection there. But most often, it is administered intravenously. Okay? And when you give it like that, the deoxycholic acid, known as ABDC, okay, the deoxycholic acid will dissociate from the ampho-B, and then the ampho-B can bind to the plasma protein binding, mainly albumin, and that plasma protein binding is high. It's in the 90s also. And if you see or if you look at the half-life for amphotericin B, it's biphasic. The initial half-life is 24 hours, and the final half-life is in terms of days, okay? About 15 days is the terminal half-life. There's no metabolism to speak of in terms of ampho-B. It is not biotransformed in any way. And excretion is usually through the renal system, but it is very slow. You only get about 2 to 5% of the drug being excreted through the renal system. It is so slow that even 7 weeks after you had given the last dose of ampho-B, you can still see molecules of the drug in the bloodstream. Okay, so that's it for this ADME. The indications for amphotericin B. One would be mycosis. Ampho-B is still the gold standard for treating life-threatening systemic mycosis. Okay, so it's still the main drug for treating life-threatening fungal infections, within the system. Okay, but it can also be used prophylactically. Okay. For instance, if you're doing bone transplantation, you can see ampho-B being used, albeit at a small dosage, 0.1 milligram per kilogram per day, for 24 hours. So you can use it prophylactically when you're doing bone transplantation. And then, of course, you can use it for treatment of other fungal infections. Usually you give a test dose when you want to give Ampho-B. That is because of the hypersensitivity reactions that you see in patients. Okay? So you just put something like 1 milligram of Ampho-B into 20 to 30 cc's, of your D5W, and you just slowly infuse that over like an hour to an hour and a half. Some people use 30 minutes, but preferably 1 hour. Okay. And then you look for indurations, and skin reactions and stuff like that. So after the test dose, if you don't see any type of hypersensitivity reaction, and then you can use as an initial dose for any treatment of fungal infections, you can use something like 0.25 to about 0.3 milligrams per kilogram for 24 hours of Ampho-B. And that can be increased to anywhere from 0.5 to about 1 milligram per kilogram per 24, but never to exceed 1.5 milligrams per kilogram of Ampho-B. Do not exceed 1.5, not greater than 1.5 milligrams per kilogram for 24 hours of Ampho-B. Some of the old myths have been discarded. It used to be a must for us to wrap the Ampho-B bottle or bag in aluminum foil because of photosensitivity. That's not necessary anymore as long as you're going to administer the Ampho-B within 8 hours of preparation in the IV room. So the old myth of not adding hydrocortisone to the bag has also been discarded. You can add hydrocortisone to the amphotericin bag without getting any loss of activity. And then the filtration, you can use your 0.45 micron filter without filtering out molecules of Ampho-B. So those are all discarded. Okay, so you can also use Ampho-B to treat algae infections. Algae infections are referred to as protothecosis. Okay. Your blue-green algae is referred to as cyanobacteria. Okay. That's the blue-green algae. So these others are just called prototheca. Without one that is Wykerham. Prototheca Wykerham. That's the commonest of all your algae or algae, depending on which English you want to use. That is very common in producing protothecosis. These are organisms that can exist in water, warm water. You get in there, you can inhale the trophozoite, and it goes to the brain somehow. So that's one of the protopickers that can infect humans. Okay. And there's one cutis. There's one that is called Protopicus cutis that also infects human beings. But Amphobae is effective against that algae. It is also effective in the management of amoebic meningoencephalitis. And that is usually caused by an amoebic type organism, which is actually a parasite that's called Naegleria. Naegleria fowleri. So Naegleria fowleri is a parasite that is amoebic in nature, like an amoeba. Okay? And that is mainly found in warm water also. So if you see people diving in rivers and other warm waters, they can inhale the trophozoite also of that Naegleria, and it goes to the brain and it causes all this meningoencephalitis. A deadly condition, very deadly. But fortunately, we have Amphobae. And then the one that we mentioned, leishmaniasis. Leishmaniasis. Let's see if we can quickly do this. You have L. donovani, that is Leishmania donovani. Okay. This is the one that produces or causes that visceral leishmaniasis. Visceral leishmaniasis. And that's the one I said you have to use Ambison, for treating. And then you have L. major and tropica. Okay. These two can cause cutaneous leishmaniasis. If you ever see a condition in your reading that is called dum-dum fever or Calaeza. Okay. Dum-dum fever or Calaeza. Those are other names for that visceral leishmaniasis. Around 1981, 82, this was thought to be the cause of AIDS because the symptoms look just like the symptoms of AIDS. And when certain drugs were used, like your pentavalent antimony drugs and your stibogluconate and pentamidine, it worked. I mean, each one of them worked, seemed to relieve some of the conditions that you see in AIDS patients. So it was thought that AIDS was actually caused by Leishmania donovani until, of course, the actual causative agent was determined. But dum-dum fever, Calaeza, those are other names for your visceral leishmaniasis. What you get with this container, sometimes you hear of oriental sore. Okay. That's a disease condition that you will get, or also for tropical sore. Those are caused by your tropical or major. And then you have El Mexicano, and that, of course, is your mucocutaneous leishmaniasis. If you ever hear of chiclero ulcers, that's mucocutaneous leishmaniasis, and it is caused by L. mexicana, and also Leishmania brasiliensis. Okay, so these two will cause your mucocutaneous leishmaniasis. So for all these cutaneous and mucocutaneous, you can use all these other amphobe preparations, but not the visceral. Okay. And I'll just finish up with the immediate adverse effects of amphobe. So when you give amphotericin B, you can get immediate and then long-term adverse effects. The immediate adverse effects can be things like your nausea and vomiting and diarrhea, can be arthralgia, it can be myalgia, all those can be present, can be fever and chills. And I'll just put rigors, because that's shaking chill, that's rigors. Can be all of those. You can see a drop in blood pressure, and phlebitis. All of those can be present. Sometimes tachycardia, maybe present. And anorexia, which you have to manage with, anyway, we'll see how you manage all of this. For the management of the anorexia, you can use alternate day therapy for your amphotericin B. Okay. For the tachycardia, you can just give a beta blocker to prevent that from happening, or you can slow down the rate of administration of the amphobe. Okay. If you slow down the rate, you'll be less likely to get tachycardia or even tachypnea, change in respiration. Okay. The phlebitis, you administer heparin. Okay. You heparin to prevent that. Phlebitis, dantrolene or meperidine can be used to manage or prevent these rigors, that is shaking chills. Okay. Dantrolene or meperidine can be useful in that. And the meperidine can also help with the myalgia and arthralgia, because those are just painful, mostly painful joints. And then you can see phenergan being administered early, that is pre-medication, that is to prevent the nausea and vomiting. That is an immediate adverse effect of your ampho-B. Hydrocortisone can also be used as a pre-medication for ampho-B therapy. So your glucocorticoid can decrease or prevent any inflammatory condition by addressing those immune factors or immune system factors, your interleukin, your TNF alpha, your prostaglandins. Okay. And then you can just see regular Tylenol being given to the patient before ampho-B as a pre-medication. You can see aspirin being used, and then you can see your NSAIDs being used. All of those can be used as pre-medication to prevent the immediate adverse effects of amphotericin B. They will pick it up from there on Monday to finish the adverse effects and then move on to the azoles. All right, questions?
In the very beginning, I forgot which class it was specifically, but you had stated that it decreases potassium as well as increases potassium as far as
That's the Casper function.
function. And one was the serum, one was it was potassium in general. And I'm assuming one is intracellular and extracellular as far as what you're referring to.
No, they both will be going on. It's just that the net effect, the net effect will be the increase in potassium in the serum. So we're not talking about whole blood. Right.
So once it goes extracellular, that's when we're assessing that serum.
Right.
So and if you ask that question on the exam, you'll refer to that serum concentration, not the intracellular. I guess that's my question.
It will not be confusing when I ask the question. Okay. You know precisely what you want to